Today, we're diving into a really important study from JAMA Network Open. It uses a clever co-twin control design to answer a fundamental question. What is the direct link between trauma in childhood and the most difficult-to-treat forms of depression? So first, let's be clear about what we're talking about. Treatment-resistant depression, or TRD, is a severe form of major depressive disorder that just doesn't get better with standard treatments. It affects a huge percentage of patients, up to 55%, and, very worryingly, it's linked to a much higher risk of suicide. And this brings us right to the core question. What is it that makes someone so vulnerable to this really severe illness? Well, this new research points to a powerful factor from early life, and what's key is that it seems to act independently of the genetics and family environment that always complicate the picture. To really appreciate just how significant this study's findings are, we need to first understand the clinical context and the scientific puzzle that the researchers were trying to solve. Okay, so let's look at the clinical reality. We know major depressive disorder is incredibly common, but for more than half of patients, it can become treatment-resistant. And this progression means more severe symptoms, a greater need for healthcare, and tragically, much higher rates of suicide. And this leads us to a huge research dilemma. You see, we've known for a long time that adverse childhood experiences, or ACEs, are a risk factor for depression. But the question has always been, do these experiences directly cause TRD, or is the connection just a side effect of shared genetics and family environment? So how did the researchers untangle such a complex relationship? Well, it all came down to a really elegant study design. The investigators pulled data from two large groups within the famous Swedish twin registry. After carefully excluding for other psychiatric conditions, they ended up with a very robust final sample of nearly 18,000 twins for their main analyses. And the precision here was absolutely critical. Their definition for exposure, the ACEs, was based on 7 specific traumatic events that happened before age 19. And the outcome, TRD, required not just a diagnosis, but also the documented failure of at least 2 different antidepressant trials. Now here's where the design gets really powerful. See, typical studies can't separate the trauma from the environment it happened in, but by comparing over 1,300 pairs of twins, where one twin was exposed to a trauma and the other wasn't, the researchers could control for 100% of shared genes and family factors. This is how they could isolate the direct impact of the trauma itself. This unique design led to some incredibly clear and compelling findings. So let's dive right into the data. First off, let's just talk about prevalence. In this massive group, nearly a third of all individuals reported experiencing at least one ACE. That alone tells you just how common these adversities really are. And if we drill down a little deeper, 5.6% experienced what we'd call a high burden of trauma, meaning 3 or more different types of ACEs. This is a particularly vulnerable group. Okay, but here's the crucial point. When you flip it around and look only at the people who actually developed TRD, the picture becomes even sharper. A staggering 61.3%, a clear majority, had a history of at least one adverse childhood experience. What the data showed was a stark dose-dependent relationship. The odds of developing TRD went up significantly with each additional ACE. For instance, with one ACE, the odds were about 2.3 times higher. That jumped to over 4 times higher for 2 ACEs, and nearly 7 times higher for 3 or more, compared to someone with none. But of course, this is the multi-million-dollar question, isn't it? The whole reason for this sophisticated study design. Does this strong connection hold up, even after you account for all those potential family and genetic factors? And here we have the answer. In Model 1, which includes all the twins, any ACE exposure carried an odds ratio of about 3.6 for TRD. But now look at Model 2, the co-twin analysis. When you control for all the shared family factors, that odds ratio skyrockets to 8.74. This is incredibly powerful evidence that the effect of trauma is independent. The study also looked at which types of adversity carried the most risk. And while nearly all of them were significant, 2 really stood out: physical neglect and sexual abuse, which had the highest odds ratios of all. And this is really important. The analysis also compared the risk for standard major depressive disorder versus the more severe TRD. The results were consistent and clear. The link with ACEs was consistently stronger for TRD. This suggests that childhood trauma might not just contribute to getting depression, but it might specifically fuel the mechanisms of treatment resistance itself. So what does all of this data mean for actual clinical practice? let's take a look at the implications. So, how exactly does this work? Well, the researchers suggest a few pathways. Early trauma can cause long-term changes to the body's entire stress response system. It's also linked to things like higher inflammation, reduced psychological resilience, and different coping styles, all factors that can make depression more stubborn and difficult to treat. And this all leads to a very powerful take-home message from the authors. Adverse childhood experiences are linked to a profound, dose-dependent, and independent increase in the risk for developing treatment-resistant depression. And the clinical directive that follows from this is completely unambiguous. A routine, detailed assessment of a patient's history of ACEs isn't just optional, it's imperative. It's essential for identifying those patients with depression who are at a higher risk for treatment failure. And having this knowledge allows clinicians to use more proactive, trauma-informed strategies right from the start. This leaves us with a final, critical question. Given this strong evidence, how should psychiatric care evolve? How can we change our standard intake and treatment protocols to actually integrate this knowledge and better serve our most vulnerable patients?